On that note, I'm sure we've all attended lectures where the speaker just seems to kind of drone on. I can drone with the best of them, but I would prefer not to do that. And whereas I have a number of slides here and certainly a presentation that I can roll with, nothing would make me happier, more happy, if you will, than to make sure that any questions you might have about this particular topic are answered. So please, at any point, don't hesitate to flag me, question me, challenge me. I'd rather make sure that we get those things answered than not. So this is who I am, and well, let's see here. Remote. I could use the mouse. That will work. Alrighty. This is who I am and what it is that I do, and most importantly, I have no financial disclosures for today. So, is there an underlying theme here? And the brief answer is there is. Who would ever thought that this adorable little guy on the left who could occupy himself chasing leaves in the backyard for hours on end would morph to this beast on the right, complete with house arrest collar, who would sell his soul for a cookie. But this is Rebel, and my point is stuff happens. So as we talk about scleral lenses today, it's really no different than any other clinical entity. It's not simply a matter of taking a topography, putting a lens on an eye, looking at it under the microscope and doing an overrefraction and saying our job is done. No, and as it relates to scleral lenses, you'll see there's a lot of excess baggage, if you will, that go along with prescribing for these folks, and certainly in the long-term care or management of them. Recognize that sclerals are not new. The Renaissance man, Da Vinci, in 16th century Italy, first described what could be conceived as the most rudimentary form of a scleral lens. Now, his work went largely undetected till the 1880s, when the Mueller brothers in Germany actually crafted the first scleral contact lens. The problem was twofold. One, it was made of glass, so it wasn't oxygen permeable at all, and as a result, corneas swell. And number two, it was made of glass, and they broke. And can you think of anything that could potentially be more dangerous than a lens on an eye made of glass that breaks? It was largely until the early 2000s that scleral lenses started to gain some popularity vis-a-vis these newer, more oxygen permeable, gas permeable materials. And it was Donald Ezekiel in Australia, and Ken Pullum in the UK, and Perry Rosenthal here in the United States, the founder of the Boston Lens Care Company, that really should be credited with bringing these lenses to the forefront. Simply put, you use a scleral lens for one of two reasons: either to give the patient a better view of the world, or to protect the ocular surface that's crying for help. And you can see in this slide that there are a variety of different indications for them. And we've got some case presentations here that we'll go over in a moment that will underscore those, if you will. So increased popularity of scleral lenses. They've become largely more popular because the materials, as I mentioned a moment ago, are more oxygen permeable and physiologically compatible. We have a better understanding of how to fit these lenses. Remember that a scleral lens is unlike any other contact lens that we have prescribed, in the sense that it vaults the cornea and it lands on the sclera, hence the name scleral lens. And if you think about it, all of our topography technologies, whether we're looking at Placido disc-based topography, or we're looking at shine flood camera-based tomographies, none of them really have given us good data on scleral anatomy in topography. And so with the advent of anterior segment OCT, profilometers that can image the sclera, and now we even have what's called eye print. It's literally like taking a dental impression of the ocular surface, has allowed us to get a better understanding of how to fit these lenses. What sort of topographies are best suited to a scleral lens? Well, you can accommodate a lot of topographies with a corneal design lens. But this study that was presented by Zhang and coworkers at the Global Lens Symposium back in 2015 showed that if you do an altitudinal map on the cornea, remember, an altitudinal map on a corneal topography is taking a best fit sphere and looking at the delta deviations negatively, the delta deviations positively. If it turns out from the high point to the low point of the cornea, you've got more than a 300 micron delta, there's good likelihood that that patient will require scleral lens. The challenges in fitting these lenses, they're very dynamic. We put them on in the office. We let them settle for 10 or 15 minutes. We look at them under the slit lamp. You know, usually we'll put some fluorescein in the bolus of the lens when it goes on the eye so that we can get an idea of how many microns that lens is vaulting the cornea by. But in general scheme of things, they settle over time. And kind of a good rule of thumb is that a scleral lens, when worn over an 8-hour period of time, will settle by about 100 microns. That's a little bit of a balancing act, because if we make the vault too great to accommodate for this settling, the patient gets a little bit of a retro lens cesspool. The tear film that's stuck behind the lens, trapped for lack of a better term, considering that the cornea is a living, breathing, metabolizing tissue, can become inflammatory. And in fact, there are some studies that have looked in this whole debacle of what we call midday fogging, where the patient's very comfortable with their lenses. They see very well, but by the middle of the day, they feel like they're looking through a fog. And what these studies have shown us is that there's a pretty significant amount of inflammatory mediators trapped behind the lens, and that the best way to modulate this is to use certain drops when you put the lens in the morning, and or remove the lens mid-afternoon, rinse it, fill it with fresh preservative-free saline, and put it back on for the rest of the day. So our goals in trying to make sure these lenses are not just clear and comfortable is to use very oxygen permeable materials, keep the contact lens as thin as we possibly can, because oxygen transmission through the lens is a function of the thickness of the lens, and to keep the vault minimal. Let's take a look at a few cases here. First and foremost, any questions that sort of lead into some of these cases? Scott's a 55-year-old gentleman who works in the construction trades. He had had LASIK surgery elsewhere 8 years prior, and the history is not unusual for someone who develops post-LASIK ectasia. He had a great result initially, then his vision seemed to be fading, went back to see a surgeon. Surgeon said, yeah, we can touch this up. They do an enhancement, and then a few months later, he's back there again saying my vision's fading. And at that point, the light bulb kind of goes off. You do a pentacam or a pachymetry, and you find that the patient's cornea is excessively thin, and that additional attempts at enhancing the LASIK surgery is just going to result in a more unstable cornea and subsequent corneal ectasia. The problem for Scott, as I mentioned, is he works in the construction trades, so trying to find a contact lens for him that's comfortable when you're working in a very dusty environment can be pretty challenging. An initial presentation, you can see his acuity in the right eye 20/80, left eye 20/50 with glasses. He has well-healed LASIK, some inferior corneal thinning, and epithelial pigment deposition. Now, why is that significant? Epithelial pigment deposition, or hemosiderin at the basal layer of the epithelium that you see at the slit lamp, is usually a pretty good indication that you have some interruption with tear film dynamics. Why do we get a Fleischer's ring at the base of a keratocone? Why do we get a Stocker's line at the head of a pterygium? Why do we get these epithelial pigment depositions in patients who maybe have had too aggressive of corneal surgery? There's interference with tear film dynamics. And every one of us in this room have come to understand that when you don't have good tear film dynamics, eyes don't just feel dry and uncomfortable, eyes are blurry, right? Patients tell us that incessantly. Every time you're checking their acuities or refracting, and well, I blinked and it changed, I blinked and it changed. So we know that when we see those epithelial pigment depositions, the vision is probably a little bit of an issue. And here you can see standard topography for Scott. He's got a pretty good amount of astigmatism, 5, 6, 7 diopters. Refractively, we can't get him very functional with glasses. And his topography has that stereotypical kissing doves or lobster claw anterior surface morphology that's consistent with the pellucid's marginal degeneration. Now here's Scott with the scleral lens on, and I would say this is a reasonably good fit in the sense that most corneas are about 12 millimeters in diameter. Most scleral lenses are anywhere from 16 to about 23 millimeters in diameter. So you expect the edge of the lens to overlap the limbus, both nasally and temporally, by a couple millimeters on each side. And what you really want to do is make sure that you've got adequate vault. And here you can see we've instilled fluorescein behind the lens to be sure we have adequate vault. Maybe up in the superior nasal quadrant here, you'll see a little bit of touch where we don't have adequate vault. But if you come over to the other side of the cornea, you can see a little bit of a bubble starting to form there. So you walk a very fine line. I like to say in scleral lens fitting, the enemy of excellence is perfection. And the enemy of excellence is perfection. You can chase these fits ad nauseum and really not benefit the patient. Problem for Scott, like about 40% of all scleral lens wearers, is this midday fogging, where again, there's nothing wrong with the cornea. There's nothing wrong with the eye. It's just that pool of tears or saline behind the lens is becoming contaminated. Things that we can do for that: 1 drop of a carboxymethyl cellulose-based drop in the bowl of the lens, think the Refresh franchise of artificial tears, followed by a good fill, if you will, with a sterile non-preserved saline, can make all the difference in the world. Just some considerations. I mentioned stuff happens. Remember Rebel, stuff happens. Is corneal collagen cross-linking an option? And the short answer is it is, if Scott progresses. Now, Scott, on one hand, is a gentleman who's 55 years of age. What happens to all of us at that age? Things stiffen, including our corneas. And so his cornea is inherently cross-linking, and that should bode well for him in mitigating progression. However, his cornea is pretty thin. He had LASIK, he had an enhancement, and so any naturally occurring cross-linking may be offset by the fact that the cornea is too thin to stabilize. So as Greenstein and Hirsch, in reviewing the FDA clinical trials for approval for cross-linking, have shown, yeah, patients who have had post-refractive surgery ectasia, if they continue to progress, can be stabilized with cross-linking. What about intracorneal ring segments? You know, for those of you who've been around long enough, you know these things have been around for about 30 years. A little polymethyl methacrylate, think of it like a trimming of the fingernail insert that is threaded into the cornea with the intention of stabilizing the cornea. From an engineering standpoint, it makes perfect sense. The problem is you're threading these in corneas that are not healthy corneas. And so the premise that the tissue is going to remain resilient enough to hold a fixed curvature indefinitely, i.e. stability, is a little wishful thinking. And so for most people who get intracorneal ring segments, it will be followed by cross-linking. In his midday fogging, the demon in the closet for scleral lens fitting, it really is. It's the biggest challenge that we deal with. The good news is we're making some headway. Neutrophil is a filling solution that's designed to mimic the ionic composition of the tears, and there are studies that show that when patients fill their lens with that in the morning, that they're less likely to have midday fogging. And as I mentioned, the study that has recently looked at the number of PMNs, or polymorphic neutrophils behind the lens, give us hope that maybe if we have patients put a drop of an NSAID in their eye prior to putting their lens in the morning, they'll quell any inflammation and do better in the long run. Let's shift gears and talk about George. I've known George for 35 years, and his history is an interesting one. In the early days of LASIK surgery, before it was approved here, Toronto, Canada, of course, was the mecca of LASIK surgery. And being in close proximity, we all see patients in our practice that made the migration. George went to Toronto to have LASIK surgery and had one good thing happen and one not so good thing happen. The one good thing that happened was, as an 11 diopter myope, the surgeon told him that he was too myopic for LASIK surgery. Good decision. The not so good decision is that the surgeon told him, but I have something else that might work as well. And that something else was radiokeratotomy. And I think that most of us would agree that trying to get an 11 diopter correction out of full thickness corneal radio incisions is a wee bit of a wishful outcome. So he had an 8 incision RK done in both eyes. I had an 8 incision enhancement in the left eye, in the right eye. And so if you look at George here today, well, not today, this was my initial assessment years ago, not too bad. I mean, he went from 11 diopters of myopia to about 3 diopters of myopia. But if you look at his cornea, those corneas are pretty flat, aren't they, at 33 and 34 diopters? And what happens here, of course, is, again, number one, you have not a variably prolate aspheric corneal topography. You now have a cornea that's oblate. It's flat in the middle, steep in the periphery. So you get a whole set of aberrations associated with that corneal topography that nature did not us evolve to deal with. And then number two, the real issue with a lot of folks with radiokeratotomy is the diurnal fluctuations in vision. So think about how radiokeratotomy works. You make an incision into the cornea that might be about 95% corneal thickness, and you're playing off of the epithelium's ability to mobilize and heal more quickly than the stroma. So epithelial cells will rally and migrate into that incision before stromal keratocytes can become upregulated and do what they need to do to heal. And so that whole premise of the epithelium growing into the incision, blocking keratocyte activity, is what causes the cornea to flatten and get rid of myopia. The problem is that very same structural change is what the cornea causes the cornea to do this throughout the day. And so there are 1 million people who had radiokeratotomy done in the United States, largely in the 1980s, early 1990s. And over 80% of them have gone on to need some form of additional surgery or to wear a medically indicated contact lens. So early on with George, we fit him with a reverse geometry gas permeable lens. You can see his right eye above, his left eye below, and he did reasonably well. But what also happens to highly myopic eyes is, we all know highly myopic eyes are much greater risk of developing cataracts earlier in life, glaucoma, retinal detachments, myopic macular degeneration, and the list goes on and on. So unfortunately, George developed significant cataracts and underwent cataract surgery, which is an even bigger challenge for even the most gifted surgeon, because calculating the implant to go in the eye at the time of surgery, predicated on corneas that are this flat, and obviously he's an 11 diopter myope at one time, huge axial length, right? Those two challenges make it very difficult. And his surgeon did a great job with bilateral cataract surgery, got him, as you can see here, much closer to emetropia than he was as a kid. But now he's hyperopic. Now he has those diurnal variations, and is finding it increasingly difficult to wear a corneal-based gas permeable lens, because a corneal-based gas permeable lens needs a lot of tears to float and function and be comfortable. And for most individuals, George is now in his 70s, that's no longer a viable option. So we fit him with the scleral lens. As you can see, his acuity isn't great. And part of the reason his acuity isn't great is because he's got some other issues going on here. Remember, again, stuff happens. Matt Geringer's done strabismus surgery on him for me. He sees Dr. David DiLoretto for his myopic macular degeneration. Fortunately, he's not converted to any wet form at the present, but we continue to manage George the best we can. Would corneal collagen cross-linking be a benefit to George? Remember, part of the issues he deals with day in, day out, the reason he needs to wear a scleral lens is the variability in his vision. I could have him come in and see any of you at 8 in the morning, noon, and 4 in the afternoon, and you would get 3 very different refractions just by virtue of this diurnal variability. The problem with cross-linking in patients that have had radiokeratotomy is that the effect wanes over time. So whereas he could conceivably have cross-linking will stabilize the cornea, but he still has those radio incisions, which means he's probably not going to get the desired effect. How about a piggyback implant? Could we get George a little better outcome if we sent him back to the operating room and either explanted his current PCIOL and put another one in under the guidance of intraoperative aberrometry, or maybe even piggyback a lens over top of his existing phakic or aphakic IOL? And the short answer is, this study done by Curato, they looked specifically at patients having radiokeratotomy that were undergoing primary cataract surgery with the benefit of intraoperative aberrometry, and guess what they found? It really wasn't any better than the best IOL calculations. And they said the Barrett True K means by way of calculating the IOL power proved to be best. Maybe the answer for this individual or individuals like George will be the IC8, the small aperture IOL. Our colleagues in Europe who've been working with this platform for years say it's really great for patients who have highly irregular corneas and have diurnal fluctuations because of their corneal condition. This is a little bit like a pinhole implant. Studies show that the depth of focus, the quality of vision, the quality of life is significantly better. And surprisingly, because it's implanted in the posterior chamber at the nodal point of the eye, patients' peripheral visions are very good. The only issue is it can make the world seem a little dimmer and a little darker. And so for that reason, the prevailing trend seems to be more to do a regular implant in one eye, and then the more symptomatic eye get this particular implant as opposed to bilaterals. Any questions? I keep droning on. So Jane's an interesting woman who was, she was teaching English as a second language in Korea when she went on holiday. And holiday was a 2-week whitewater rafting expedition during which she wore her soft contact lenses. Nonstop, 24/7, 2 weeks. Finally, by the time she landed back in Seoul, her base, she had some pretty significant symptoms of what she thought was conjunctivitis. Well, it turned out that she had bilateral acanthamoeba keratitis. Can you think of anything more devastating than bilateral acanthamoeba keratitis? She was treated very, very successfully, but when she came back stateside here and presented to me, her comments were that she just couldn't function well with spectacles. Back in Korea, they had tried some gas permeable lenses that were uncomfortable, and she wanted to know if she was a candidate for LASIK surgery. Interestingly enough, at the time of my initial consult, she was also on prednisolone 1% and covered with Zovirax ointment for a presumed herpetic infection, but there wasn't any evidence of herpetic infection at the time of evaluation. Top slides are right eye, and you can see a disc-shaped stromal leucoma. Bottom eye, you can see this big hemispherical area of scarring. And if you look at Jane's refraction, her right eye corneal topography looks pretty good, and her refraction showed very little cylinder. She could actually function well with glasses there. But her left eye, she's got this bow tie against the rule astigmatism bow tie. Why is that important? Generally speaking, corneal design lenses will center over the apex of the cornea, and corneal design gas permeable lenses always work better on with the rule corneas, because with the rule corneas are steep vertically and flat horizontally. And when the patient blinks, the lens moves in harmony with the eyelid, so it's very comfortable. If you end up with someone with about 5-6 diopters of against the rule astigmatism, which is what Jane has on her left eye, every time she blinks, her lens moves left to right, not up and down. That tends to be really annoying. And so when I sat down with her and chatted, it was apparent that she could do pretty well with a corneal design gas permeable lens on her right eye. But on her left eye, as you can see in the bottom, we needed to fit her with the Scleral lens. In other words, we just couldn't find a corneal design lens that was stable and comfortable. And so as a result, went this route. And she's done reasonably well. A couple comments about acanthamoeba real quickly. We used to think acanthamoeba was a disease of soft contact lens wearers in hot tubs, right? That's so 1980s, 1990s. Now what we're seeing is a lot more acanthamoeba. Part of it is probably because we're making diagnoses much earlier and much more efficiently. But part of it is also what's happening with global warming. Part of it is also what's happening with what municipalities will do with their water sources. And this became very apparent in Chicago about 15 years ago or so, when the Cook County Water Authority decided to reduce the amount of chlorine in the municipal water source, and the number or the relative risk of acanthamoeba increased almost 7-fold in ophthalmology and optometry practices throughout the Chicago metro area. The good news, as I mentioned, is we've got better ways of diagnosing it early. We've got better ways of treating it. But from a frontline primary eye care perspective standpoint, really the only contact lens care products in the marketplace that are really effectively cysticidal against acanthamoeba are the hydrogen peroxide systems like Clear Care. And that's why in Jane's case, we were using just that. We are almost out of time here. Is that right? Yeah, I'll finish here in just a minute with a gentleman, bilateral Fuchs corneal dystrophy, bilateral cataract surgery, A lot of astigmatism in his left eye, had a PTK, UV exposure, woke up a latent herpes virus. This poor guy's got dry eye, glaucoma, a whole host of things going on. Initially tried to fit him with what's called a prolate design, but as you can see here, the lens isn't vaulting very well, ended up needing to go, I'm sorry, with an oblate design, go with a prolate design. Eder's a retired mathematics professor at RIT, and our scleral lenses indicated in a case as extensive as his, really bad dry eye, corneal transplants, history of herpes, history of glaucoma. And the short answer is they are. The more complex the patient, sometimes the better the outcomes for these folks. But we never want to lose sight of the fact that things happen. The study out of the UK showed that glaucoma does impact graft survival. So we need to make sure we're managing his glaucoma effectively. Do scleral lenses affect intraocular pressure? Did they make it harder for us to control glaucoma? The thought is that a scleral lens sits on the sclera. It may compress venous or episcleral venous outflow and cause increased intraocular pressure. That's been refuted. Should we avoid a prostaglandin? We all know prostaglandins are great first-line therapy in lowering intraocular pressure, but there are some case reports that show that they can wake up or exacerbate a latent herpes simplex virus. So we tend to avoid that. And that's why, unfortunately, Eder's on 2 different anti-glaucoma medicines, none of which are a prostaglandin. So I will say we're at the end of time here. Thank you for your time and attention. And if we just make provisions and we know stuff's going to happen along the way, good things will come out. For Rebel, who knew it was as simple as an orange tennis ball? But that's all it took. Thank you. Thank you, Jennifer.